Dear students, start our lecture class. Today we discuss about hemodynamic disorder. Hemodynamic disorder includes the following topics. These are edema, hyperemia and congestion, thrombosis and embolism, hemorrhage and shock. All these terms are clinically very much important. And pathology is the mother of all subjects. So we should concentrate these topics. Hyperemia and congestion. Hyperemia means increased, it is an active process resulting from augmented tissue inflow because of arteriolar dilatation. Here, 3 points. One is active process, another is augmented tissue inflow, and mechanism is arteriolar dilatation. So, in both case of hyperemia and congestion, there is increased blood volume in the tissue and organ. So, in a word, there is increased blood flow in tissue or organ in case of both hyperemia and congestion. But process is different. Suppose hyperemia is an active process, congestion is a passive process. Hyperemia here increased or augmented tissue inflow. In congestion, there is decreased tissue outflow. In case of hyperemia, there is arteriolar dilatation. In case of congestion, there is venous obstruction. So, we concentrate 3 points. In hyperemia, it is an active process. In congestion, it is a passive process. In hyperemia, there is augmented tissue inflow. In congestion, there is impaired outflow. In hyperemia, process is arteriolar dilatation. In congestion, the process is venous obstruction, localized venous obstruction. But the net result is increased blood volume in the tissue and organ. Clear? In case of hyperemia and congestion, in both cases, there is increased blood volume in the tissue and organ, as well as in organ. But there is two different process. In hyperemia, it is an active process. Congestion is a passive process. In hyperemia, there is increased or augmented tissue inflow. In congestion, there is decreased tissue outflow. The process is arteriolar dilatation in case of hyperemia and venous obstruction in congestion. As there is arteriolar dilatation, we know that arterial or carries oxygenated blood. So simply this blood is red in color. Hyperemia occurs in muscular exercise, febrile condition, blushing and inflammation. You already know that cardinal sign of inflammation, one of the cardinal sign of inflammation is rubor. Rubor means redness, and this redness due to hyperemia. So, hyperemia is intimately related with inflammation. It is an important chapter. So, cardinal sign of inflammation, one of the cardinal sign of inflammation is hyperemia. If we concentrate these topics, we can solve the various clinical problems. Hyperemia occurs in muscular exercise, in febrile condition, in blushing, and inflammation. In congestion, where it occurs, we already discussed that it occurs due to venous obstruction, local or isolated venous obstruction. It may be due to this venous obstruction may occur by any external compression to these corresponding venous tributaries, or occlusion of the lumen of the vein, or paralysis of the neurogenic modulation such as in frostbite and in burn. So, a patient in burn, there may be congested area. Why? There is paralysis of the neurogenic modulation. Or in frostbite. So, it is simple: hyperemia and congestion. Congestion occur in different systemic organ, suppose in lung, liver, spleen. Clinically, there is some important presentation. If we compare hyperemia with congestion, hyperemic blood or hyperemic area is red in color, as arterial contain oxygenated blood. In congested area, the affected area becomes cyanosed, as congested blood is blue in color, venous blood. Another important topics: congestion and edema occur together. We also discuss about edema in later. So it is an very much important points. Congestion and edema occur together. Where there is congestion, there may be edema. Now, in chronic passive congestion, chronic means, you already know, chronic means long duration, and congestion is a passive process. In chronic passive congestion, there is stasis of poorly oxygenated blood. As a result, there is chronic hypoxia. It is like that of mathematics. As there is chronic passive congestion, we know that chronic means long duration, prolonged duration. As there is prolonged duration and the area is congested, we already know that what is congestion. There is collection of or stasis of blood, and this blood is poorly oxygenated. As a result, the tissue develops chronic hypoxia. There is hypoxia, which results in cell degeneration or cell death. So there is 3 points. There is chronic passive congestion, develop chronic hypoxia, develop parenchymal cell or cell degeneration or death. So there is a consequence. Chronic passive congestion causes chronic hypoxia, causes cell degeneration or cell death. We know cell death means necrosis, cell death in living tissue. So we know the one of the important causes of necrosis is hypoxia. In another word, we explain it, chronic passive congestion causes chronic hypoxia. Ultimately, there is cell degeneration or cell death. We clear? So we can summarize that if the congestion prolongs, if it turns into chronic congestion, there is a catastrophic result. There is chronic hypoxia, there is cell death. Capillary rupture at this site of chronic congestion also causes the some foci of hemorrhage. And ultimately, as there is hemorrhage means extravasation of blood. What is hemorrhage? Extravasation of blood. If these components of blood, especially red blood cell, which is composed of heme and globin, hemoglobin, there is breakdown of RBC, and ultimately it is engulfed by the macrophages, resulting in hemosiderin-laden macrophages. In normally, it is capillary, which is composed of arterioles and veins. In hyperemia, there is increased flow. Look at, there is the caliber of the arteriole or small blood vessel become increased. And as the caliber is increased, the inflow is also increased. When it occurred, we know hyperemia occurred in febrile condition, muscular exercise, inflammation. And in congestion, there is more bluish area as the venule is obstructed. There is local obstruction. Venule become obstructed. So there is increased cyanosed blood, deoxygenated blood, collection of deoxygenated blood. As there is deoxygenated blood means lack of oxygen or diminished oxygen, which is known as hypoxia. And the tissue is supplied by this blood vessel is hampered. So tissue become degenerated, resulting cell death in tissue. So in chronic congestion, tissue, ultimately there is tissue degeneration or cell degeneration or cell death. This is the figure of hyperemia and congestion. Two vital organ is affected by congestion. Congestion of the lung. When it occurs in left ventricular failure or which occurs due to myocardial infarction or myocarditis, cardiomyopathy, rheumatic heart disease with mitral stenosis, or mitral valve floppy with regurgitation. If we concentrate this figure, this hyperemia occurs in inflammation and exercise, and this congestion occurs in congestive cardiac failure and local obstruction of the vein. Congestion of the lung occurs in two ways. One is acute pulmonary congestion and another is chronic pulmonary congestion. In acute pulmonary congestion, alveolar capillaries are engorged with blood. As it is congestion, so this blood is deoxygenated blood. We know that the lung is unit of the lung is alveoli. There is alveolar capillaries, alveolar septa, and alveolar space. If we consider anatomy, look at the picture. These are the figure of acute pulmonary congestion. There is alveolar septa become edematous. Alveolar septa become edematous. And there is intra-alveolar hemorrhage. So we know that congestion and edema occurs together. Where this edema occur? In the alveolar septa. The alveolar septa. And there is rupture of some intraalveolar capillaries causes hemorrhage. Causes hemorrhage. The septa become edematous and there is hemorrhage. Alveolar hemorrhage. In chronic pulmonary congestion. Chronic means long duration. Pulmonary means lung and congestion. These edematous septa become thickened and fibrotic. In acute pulmonary congestion, there are only 2 points. One is septa become edematous and there is alveolar hemorrhage. In chronic congestion, these edematous septa become fibrotic and thickened. And the alveoli contain numerous heart failure cells. There is also 2 points. In acute pulmonary congestion, there is 2 points. One is the septa, alveolar septa become edematous and another is alveolar hemorrhage. In chronic pulmonary congestion, there is also 2 points. This thickened septa, edematous septa become thickened. This is the continuation of acute pulmonary congestion, edematous septa which become fibrotic. And in acute pulmonary congestion, alveolar space contain hemorrhage, alveolar hemorrhage known as alveolar hemorrhage. And the ultimate fate of this hemorrhage is there is breakdown of red blood cell engulfed by the macrophage, which is known as hemosiderin-laden macrophage. These hemosiderin-laden macrophages in the alveolar space is known as heart failure cell. The figure is like that. The color is hemosiderin-laden macrophages. So, if we consider this figure, this is acute pulmonary congestion. There is the alveolar septa become edematous and alveolar space contain alveolar hemorrhage. In chronic pulmonary congestion, these septa become fibrosis, which is the component of chronic inflammation. So this edematous septa become fibrotic, and these hemorrhages, fate of these alveolar hemorrhages which is present in acute pulmonary congestion, they undergo breakdown and forming heart failure cell. What is heart failure cell? Hemosiderin-laden macrophages in the alveolar space, which is the cardinal points for chronic pulmonary congestion. Ultimately, there is also hemosiderin pigmentation which is increases, and with time it is known as brown induration of lung. Color is brown, of course, hemosiderin pigmentation, due to hemosiderin pigmentation, brown induration of lung. So we clear that in lung, if congestion develop, if it is acute, there is 2 points. One is alveolar septa become edematous, and there is hemorrhage in the alveolar space or intraalveolar hemorrhage. The figure is like that. Alveolar septa become edematous and there is alveolar hemorrhage. In chronic case, these edematous septa become fibrotic and alveolar hemorrhage ultimately produce heart failure cell by the breakdown of red blood cell. So there is 2 key points in acute pulmonary congestion and 2 key points in chronic pulmonary congestion. Very simple. Now in liver, why congestion develop in liver? Congestive cardiac failure or right heart failure, obstruction of inferior vena cava, obstruction of the hepatic vein. If we consider anatomy of liver, hexagonal liver cell contains central vein centrally and portal triad peripherally. This is very much important. Anatomy of liver. Hepatic cell is hexagonal, which contain central vein centrally and portal triad in peripherally or sinusoidal space. Now, in acute hepatic congestion, there is central vein and sinusoids are distended with blood. We know that congestion occurs due to venous obstruction. So, it may develop due to obstruction of inferior vena cava or hepatic vein. So, in acute hepatic congestion, there is central vein and sinusoid. You must locate, you must remember that where the central vein is placed and sinusoid is placed. What happened in acute hepatic congestion? The central hepatocyte show degeneration and peripheral hepatocyte show only fatty change. You already know that degeneration of the cell or cell death is known as necrosis in living tissue. cell death in living tissue is known as necrosis. So central hepatocyte undergo degeneration, that means hepatic necrosis. That is irreversible cell injury. And peripheral hepatocyte undergo fatty change. It is reversible cell injury. We know that. In pathology, the students who correlate more, they understand easily. So, in acute hepatic congestion, why? The central hepatocyte undergo necrosis or degeneration and peripheral hepatocyte undergo fatty change. I already mentioned that the anatomy of liver, there is hexagonal hepatocyte which contain central vein in their center of the cell, and peripherally there is portal triad. As there is central vein contain the deoxygenated blood, there is hypoxia, there is cell death. So there is hepatic necrosis centrally. And peripheral hepatocyte having another supply from portal triad. So there is hypoxia, but it is less evident. So there is a reversible cell injury, that is fatty change. In chronic hepatic congestion, we know that in acute pulmonary congestion, there is edematous septa and alveolar hemorrhage. In chronic congestion, there is fibrotic septa and heart failure septa. In acute hepatic congestion, there is also engorgement of the central vein and sinusoid by the deoxygenated blood, and the central hepatocyte undergo necrosis or irreversible cell injury, and the peripheral hepatocyte undergo reversible cell injury, as it is supplied by the portal triad, where blood supply not totally obstructed. In chronic hepatic congestion, the central region become grossly red brown. That is, this we already know that in central hepatocyte undergo necrosis, and there is also deoxygenated blood, and there is breakdown of this red blood cell. Ultimately, there is hemosiderin laden macrophage. So, microscopically, there is centrilobular necrosis with loss of hepatocyte or dropout of hepatocyte, and hemorrhage including hemosiderin laden macrophage. Clear? And peripheral hepatocyte undergo less hypoxia as it is supplied by the portal triad. So there is only fatty change or reversible cell injury. In severe long-standing hepatic congestion, there is fibrotic thickening of the wall of the vein and central sinusoids. Wall of the vein, when it becomes thickened, consistency is more, which leads to cardiac sclerosis, which is known as cardiac cirrhosis. Due to increased consistency of the vein, which it is known as cardiac, and it is liver, it is cirrhosis, cardiac cirrhosis. So, in a word, in chronic hepatic congestion, there is centrilobular necrosis surrounded by the uncongested liver substance. There is no existence of proper hepatocyte. These undergo necrosis, and which are surrounded by the peripherally is uncongested liver substance, like that of this figure. Now, edema. So, if we summarize congestion and hyperemia, if we summarize, in both case of hyperemia and congestion, there is increased blood volume in the tissue or organ. In hyperemia, it is due to arterial dilatation, and in congestion, it is due to venous obstruction. One contains oxygenated blood, so color of the blood is red, and another is deoxygenated blood, so patient become or affected area become cyanosed. Hyperemia occurs in muscular exercise. In muscular exercise, there is also arterial dilatation. In febrile condition, there is also arterial dilatation and inflammation. One of the cardinal signs of inflammation is rubor or redness or hyperemia. In congestion, it may be acute, may be chronic. In acute pulmonary congestion, there is two things. If we consider the figure, in a short we said that there is alveolar septal edema and there is alveolar intraalveolar hemorrhage. In chronic pulmonary congestion, this edematous septa become fibrotic, and this consequence of this collection of intraalveolar hemorrhage into heart failure cell. What is heart failure cell? Hemosiderin laden macrophage. In case of chronic pulmonary congestion, this is the key points. And together with hemosiderin pigmentation, it is known as brown induration of lung. In case of liver, it occurs in right heart valve. It is most important. It is caused by congestive cardiac failure, obstruction of inferior vena cava, or hepatic vein. In acute hepatic congestion, there is 2 points. One is central vein and sinusoid. You must know that the central vein and sinusoid, where these are located within the liver. In anatomy, you clearly know that the central vein is placed on the center of the hepatocyte and sinusoids, where these are located. Both of these are distended with deoxygenated blood. As the central hepatocyte supplied by this, so there is deoxygenated blood, there is hypoxia, there is cell death in central region of the central hepatocyte. But peripherally, there is only irreversible changes as it is supplied by the portal right. In chronic case, there is central region become depressed and surrounded by the uncongested liver substance give rise to nutmeg liver. What is cardiac cirrhosis? When in long-standing case, fibrous thickening of this vessel, these are central vein, sinusoids. This thickening is known as cardiac sclerosis. Though it occurs in hepatic congestion, it is known as cardiac sclerosis. The figure is like that. The central region undergo necrosis and these are surrounded by the uncongested liver substance. These cells show only fatty change and these are undergo necrosis. Nutmeg liver. When there is more thickening of the central wall of the central vein and sinusoids, it is known as cardiac cirrhosis. Now, edema. Edema is accumulation of abnormal excess fluid in the interstitial tissue space or body cavity. These are clinically important where there is excess of fluid by 10%. There are some clinical terms, what is ascites or hydroperitoneum. If this edema present in or excess fluid present in peritoneal cavity, hydrothorax or pleural effusion, hydropericardium, hydropericardium, excess fluid in the pericardial cavity. Classification of edema. It may classified by the nature of fluid, inflammatory or non-inflammatory. Inflammatory edema, the nature of the fluid is exudative. That means this fluid is rich in protein and specific gravity is more than 1020. If the edema fluid is non-inflammatory, this is known as transudative. This fluid contains low protein and specific gravity is less than 101. On the basis of location, if it is localized or it is generalized. Localized edema occurs due to inflammatory edema, hypersensitivity edema, edema due to local venous obstruction or lymphatic obstruction or lymphatic edema. Another important term is very much important for your exam. What is anasarca? That is generalized edema. When it occurs, it may occur due to cardiac edema, renal edema, hepatic edema, nutritional edema, protein losing enteropathy, edema due to adrenal hormone, myxedema, pregnancy, or unexplained. This is a figure of elephantiasis. Limb like that of elephant. Elephantiasis is the enlargement and hardening of the limbs or body part due to tissue swelling. It is characterized by edema, hypertrophy, and fibrosis of the skin and subcutaneous tissue due to obstruction of the lymphatic vessel. It may occur in genitalia. So, elephantiasis is an edema due to lymphatic obstruction. Simply, edema due to lymphatic obstruction. This is very much important. You already know the pathophysiological classification or pathophysiological type of edema. There are four mechanisms. Increased hydrostatic pressure. Before this, we know that why usually edema does not occur. There is a balance between hydrostatic pressure and colloidal osmotic pressure. When there is this hydrostatic pressure is increased, there may be edema. This hydrostatic pressure depends upon venous return. Mainly, as this venous return is impaired, there is increased hydrostatic pressure and results in edema. Impaired venous return. When occurred? It occurs in congestive cardiac failure, constrictive pericarditis, cirrhosis of liver, or local venous obstruction by thrombus or any external pressure and lower extremity with prolonged dependency. Another mechanism of increased hydrostatic pressure is arteriolar dilatation. Why this arterial dilatation may occur? By the heat or neurohumoral excess or deficit. So, pathophysiology of edema, one of the most important causes increased hydrostatic pressure, which is occurred due to impaired venous return and or arterial dilatation. Another important mechanism is reduced colloidal osmotic pressure. We know that colloidal osmotic pressure is maintained by the plasma protein. So, if due to any cause there is loss of protein, that is hypoproteinemia, decreased protein level in blood, it may be due to protein losing glomerulopathies or nephrotic syndrome. It may be due to cirrhosis of liver, as plasma protein is produced by the liver, or decreased protein by malnutrition, decreased protein intake by malnutrition, or any excess loss by protein losing gastroenteropathy. In a word, there is decreased protein level in blood. Reduced plasma osmotic pressure causes edema. First important cause is increased hydrostatic pressure, which may occur due to increased impaired venous return or arterial dilatation, and reduced colloidal osmotic pressure due to hypoproteinemia. Another important cause is renal retention of sodium. When it occurs, due to excess salt intake with renal insufficiency or increased tubular reabsorption of sodium. May be due to renal hypoperfusion or increased renin-angiotensin-aldosterone mechanism. Fourth point is lymphatic obstruction. We already discussed it. It may be due to inflammation, may be due to neoplastic or post-surgical or post-irradiation. And another is inflammatory. It may be acute inflammation or chronic inflammation or angiogenesis. Angiogenesis means generation of new blood vessel. So, pathophysiological mechanism or pathophysiological classification of edema, in a word, number one is increased hydrostatic pressure, two, reduced colloidal osmotic pressure, three, renal retention of sodium, number four, lymphatic obstruction, and number five is inflammatory. If there is increased hydrostatic pressure, fluid may comes out from blood vessel, causes edema. Or if this colloidal osmotic pressure is reduced, there is also edema. Increased hydrostatic pressure or decreased colloidal osmotic pressure. Cardiac edema. In cardiac edema, there is most important point is heart become diseased or inactive. If there is heart failure, there is decreased cardiac output. This cardiac output become decreased by another cause, malnutrition, cirrhosis of liver or hepatic synthesis of protein, or nephrotic syndrome, there is decreased colon osmotic pressure, decreased blood volume. If there is decreased blood volume, there is decreased cardiac output. Or if heart failed due to any cause, there is also decreased cardiac output. If cardiac output is decreased, there is decreased effective circulatory blood volume. If blood volume is decreased, there are three incidents. Number one is increased renin secretion. Number two is increased adage secretion, antidiuretic, and another is increased vasoconstriction, renal vasoconstriction. So, if there is very much important point, if there is decreased arterial blood volume, if there is decreased circulatory blood volume, there are three incidents. One is increased renin secretion, another is increased adage secretion, and third point is renal vasoconstriction. We recall this point. In heart failure, there is decreased cardiac output. Or if this cardiac output is decreased due to any cause, there is decreased effective circulatory blood volume. If there is decreased circulatory blood volume, there are three incidents. One is increased renin secretion, increased adage secretion, and another is renal vasoconstriction. Now, the effects of these 3 points. If there is increased renin secretion, there is increased aldosterone. And this aldosterone causes renal retention of sodium. This aldosterone causes, by the activation of angiotensin 2, there is renal retention of sodium. As sodium is isosmotic substance, it enters into the blood vessel with water. So there is increased blood volume or plasma volume, which causes transudation or edema. There is increased hydrostatic pressure. There is increased hydrostatic pressure, as well as ADH increase the renal retention of water directly, which increase renal retention of salt and water. Ultimately, there is increased plasma volume, there is increased hydrostatic pressure, and there is edema. And the effects of third point is renal vasoconstriction, which also causes tubular reabsorption of sodium and water, increased GFR. Ultimately, there is renal retention of salt and water. In case of heart failure, there is directly increased central venous pressure and capillary pressure. We know that increased capillary pressure is one of the causes of transudation and ultimately edema. If due to any cause there is renal failure, kidney try to causes retention of sodium and water. So this is the mechanism of edema due to heart failure or malnutrition, or that is decreased colloidal osmotic pressure. Another important point is hepatic edema, which is also important for your viva and written exam. Hepatic edema. It may occur in cirrhosis of liver or any cause. We know that there are four mechanism or five mechanism of edema, pathophysiological classification of edema. First is increased hydrostatic pressure. In case of hepatic edema, if there is portal hypertension, there is increased hydrostatic pressure. Number two is decreased colloidal osmotic pressure. As the liver is diseased liver cannot synthesize plasma protein properly. So there is hypoalbuminemia. Ultimately, there is decreased colloidal osmotic pressure. Third point is renal retention of sodium and with renal increased sodium retention with renal insufficiency. In case of hepatic edema, it is known as secondary hyperaldosteronism. There is less activation of aldosterone by the liver. Less inactivation of the aldosterone. So there is hyperaldosteronism. As it is occurred in liver, not in the adrenal gland, it is known as secondary hyperaldosteronism. So what do you mean by primary hyperaldosteronism? If there is increased level of aldosterone due to adrenal gland cause, it is known as primary hyperaldosteronism. Here, hyperaldosteronism occurs due to less inactivation of aldosterone by the liver, which is known as secondary hyperaldosteronism. We ask, what is primary and secondary hyperaldosteronism? The result is retention of sodium in water. Another is obstruction of hepatic lymphatics. That is lymphatic obstruction. So, in case of cirrhosis of liver, the four mechanisms are applied. Number one is increased hydrostatic pressure due to portal hypertension. Number two is decreased colloidal osmotic pressure by the decreased synthesis of plasma protein by the liver. Number three is secondary hyperaldosteronism. Number four is obstruction of the hepatic lymphatics. Pulmonary edema. As there is entrance of excess fluid in the interstitial tissue space, this excess fluid raises the interstitial fluid pressure from negative to 0 and eventually exceeds the negative pressure of the alveolar surfactant, leading to onset of the alveolar flooding. That is, alveoli contain this excess fluid. The capillaries become deprived their oxygen supply. As the alveoli is full of fluid instead of air, the cell become hypoxic. The vascular permeability increases and protein-rich fluid accumulates and spreads into the adjacent alveoli. Ultimately, there is pulmonary edema. And one important thing, if the pulmonary edema once formed, it spreads rapidly through the whole lung. Why it is occurred? It is very much important causes of pulmonary edema. Number one and very much important, that is left heart failure. You know that pulmonary edema, causes of pulmonary edema, one of the most important causes left heart failure. Another is withdrawal of the pleural effusion, cerebral damage, oxygen toxicity, lung infection, drowning, aspiration pneumonia, radiation, uremia, and toxic irritation. And the figure is like that. Pulmonary edema. The alveolar spaces contain fluid instead of air, and the protein-rich fluid that spreads through the pore of cone to the adjacent alveoli and spread rapidly. The vascular permeability become increases. These are all about edema.